Very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Wojciech Zurzak from Poland, and he's going to lecture us on relapsed refractory large B-cell lymphoma after ASH 2024. This webinar is brought to by Mumbai Hematology Group, supported by Lucien Life Sciences and managed by Perfect Square. I thank Mr. Srivastava and team Lucien, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Anup Tosniwal from Aurangabad. Our guest speaker for the day, Professor Dr. Wojciech Zurzak from Poland. All our discussants who are themselves very eminent hematologists as well as hemato-oncologists. And you participants for sparing the Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give flavor of our next weekend activities. Next Saturday, that is 18th of January 2025, from 7 p.m. Indian Standard Time and 8:30 a.m. USA time, we have Dr. Cindy Nunat from New York speaking to us on ITP and update from ASH December 2024. And the following day, that is Sunday, 19th of January 2025, from 11:30 p.m., 11:30 a.m. IST, we have Colonel Dr. Uday Yanamundra from Armed Force Medical College, Pune, speaking to us on monoclonal gammopathy from MGUS to MGCS. Let me introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Ashish Dixit from Comprehensive Cancer Center, Manipal Hospital, Bangalore. Dr. Chirag Shah from Apollo Hospitals International, Ahmedabad. Dr. Ganesh Jeshetwar from Yasoda Hospital, Hyderabad. Dr. Girish Badarke from HCG Manokda Cancer Center, Nasik. Dr. Hari Menon from St. John's Medical College Hospital, Bangalore. Dr. Hemant Malhotra from Mahatma Gandhi Medical College Hospital, Jaipur. Dr. Lalit Kumar from AIIMS, Delhi. Dr. Mallikarjun Kalla Shetty from Comprehensive Cancer Center, Manipal Hospital, Bangalore. Dr. Urmi Sheth from Dinanath Mangeshkar Hospital, Pune. Dr. Varun Bafna from Dr. Bafna Star Clinical Hospital, Kolhapur. Now, it's time to introduce our special guest and chief guest for the day. We have with us Dr. Anup Tosniwal from Aurangabad. Dr. Anup Tosniwal is consultant medical oncologist and hemato-oncologist, director and founder of Shri V Care Clinic at Chhatrapati Sambhaji Nagar, Aurangabad, Maharashtra. He did his MBBS from Government Medical College, Aurangabad, followed by MD Medicine from Kasturba Medical College, Mangalore, followed by DM in Medical Oncology from very prestigious Tata Memorial Hospital, Mumbai. He subsequently cleared the European Society of Medical Oncology examination and was awarded fellowship for clinical research from Australian Clinical Oncology Research Society. He is also an executive committee member, Western Zone, Indian Society of Medical and Pediatric Oncology. He is a reviewer for Indian Medical and Pediatric Oncology Journal, as well as South Asia Oncology Journal and Curious Journal of Medical Science. He is Assistant Professor of Medical Oncology in Government Cancer Hospital, Chhatrapati Sambhaji Nagar. He has more than 10 international research papers and publications. He is the first qualified DM in medical oncology in Marathwada and Central Maharashtra. It's my privilege to welcome Dr. Anup Tosniwal to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Anup Tosniwal.
Thank you, Dr. Amit. It is a privilege to be here. I thank MB Agrawal sir for inviting me among these stalwarts of discussants. I think I'm the junior most person, and still he gave this opportunity to talk to here for you all for 1 to 2 minutes. So he just asked me to tell about the bright future of hemato-oncology in India. Not only we require a lot of hemato-oncologists due to shortage in number for underprivileged and underserved area, but also to generate our own data. Because what we do is we depend upon data from Western country, but our genomics are different. Our cost, our service methodology is different. So we need a lot more people. We also need people to advocate inclusion of newer modalities of treatment for hemato-oncology in government and private insurances, because what I find in day-to-day practice is that newer drugs, newer modalities like ADCs, CARs, BMTs, they are not included for underprivileged people in our country in government programs. Coming to today's topic, It's a very required session because there are a lot of new excitement after 20 years of almost insignificant 2 decades of no much real progress happening in this field. A lot of ADCs, car, trucks, bite, theranostics updates have been come. There are newer cellular therapies like gamma delta, T-cell receptor therapies coming up in solid as well as hemato-oncology. And it would be very we're fortunate to have such a good speaker to enlighten about this very much required topic. With these 2 cents of my wisdom, I hand over the proceedings again back to Amit sir to ask our guests to enlighten about the topic. Thank you.
Thank you, Dr. Anup Toshniwal, for that wonderful, kind words and reflecting your views on this topic. And thank you for accepting our chief guest for the day. Thanks a lot. Let me share the screen again. So now it's a time to introduce our guest speaker for the day. We have with us no other than Dr. Wojciech Jurzak from Poland. He has been our speaker multiple times and he talks wonderfully. His speech is excellent and he's a wonderful teacher. Dr. Wojciech Jurzak is MD, PhD, consultant and professor of hematology from Memorial Maria Sklodowska-Curie National Research Institute of Oncology, Krakow, Poland. He is a consultant and professor of hematology at Jagiellonian University, Krakow, Poland, where he leads the lymphoma team since 1992. Most of his research activity in the first 15 years is related to development of monoclonal antibodies in B-cell lymphomas and practical aspects of stem cell transplantation. At Jagiellonian University Lymphoma, he leads and has participated in over 70 clinical trials, including phase 1 and phase 2, followed by expansion cohorts. He is a co-author of publications leading to registration of ibrutinib, adalimumab, belinostat, lenalidomide, venetoclax, and rituximab biosimilars. At present, his research is focused on developing future generation BTK inhibitors, as well as anti-PD-1 molecules, DARTs, and BiTEs. He is a member of numerous scientific societies, including ASH, ASCO, PLRG, EMCLN, and ICOS, and consultant for EMA, that is European Medicines Agency. His research papers have been published in NEJM, Blood, JCO, the Lancet, Lancet Oncology, Annals of Oncology, etc., with a cumulative IF of more than 650, H index of 20, and citations of more than 3,000. And today, again, he is with us and he's going to lecture us on relapsed refractory large B-cell lymphoma after ASH 2024. Well, thank you so much. Over to you, Professor.
Amit, thank you so much for this kind invitation. Let me just see whether that works. I thought I would just tell you about large B-cell lymphoma after ASH, not just relapsing refractory. And there will be one missing thing, namely, I will not tell you about CAR T cells. I will not tell you about the CAR T cells because I got the impression that ASH was full of CAR T cells, but they are not available for everyone. So in some hospitals, we have to deal with, from the perspective where CAR T cells are done elsewhere. So starting from scratch and starting from one of the first minor pieces forward, namely POLARIX study. POLARIX was updated on ASH meeting by Gilles, and POLARIX was the first randomized study in a first-line diffuse large B-cell lymphoma, which was one minor medical but step forward. It was the first and the only randomized clinical trial so far which has demonstrated the superiority over R-CHOP, which was our standard for the last 20-25 years. So in POLARIX, we took all previously untreated diffuse large B-cell lymphoma with intermediate or high risk. And the whole group was randomized against R-CHOP versus R-CHOP plus placebo versus polar R-CHOP. And looking at the subgroup analysis, we evidently had enough in double expressors, but not enough patients in high-grade lymphomas, just about less than 10%, which meant about 50% in each arm. Therefore, we may be more or less confident about double expressor lymphoma, about its efficacy in double expressor lymphomas, ABC subtypes, and so on, but not in high-grade lymphomas. And the initial progression-free survival benefit was maintained at 5 years, which is a good but expected news. What is important is that there were considerably less, namely 23% less of subsequent therapies after the polar R-CHOP, including less CAR T cells. However, which was disappointing, we had just a numerical, still not significant progression-free overall survival difference. This is what I meant, that it's a step forward, but a small and mediocre step forward. We are all looking forward for a major improvement, which is on its way, because we all understand that the battle with diffuse large B-cell lymphomas and with large B-cell lymphomas is won in the first line of therapy. All the rest is minor, as a minor contribution towards the true prolongation of life. So whatever we say, we had confirmation that if you're looking at deaths, that polar R-CHP is better, but not substantially better. And the subgroup analysis, in fact, lacks the power of, lacks this good statistical power. Now, what are other approaches? We used to have the randomized study with lenalidomide added to R-CHOP. The study as such was a failure, and was a failure because we didn't have enough high-risk cases. Besides, lenalidomide had this bad fate, as the company, at least in the Western world, kept on its patent rights, and only the brave countries like India ended it up after 10 years. In Europe and the States, lenalidomide was under the patent protection for the bloody 19 years, which meant perhaps a good profit for the company, but it checked the research. So the Golca, or golcadomide, which is a much, much better CELMoD, which is 10 to 30 times better than lenalidomide in direct anti-lymphoma action, was not investigated until recently. And we have the ongoing third phase study, which is randomizing against R-CHOP against R-CHOP with Golca. And this is one of the things we think it might be right, because if you look at the phase 1b study, additional Golca had a very promising results regardless the group, but it worked also specifically when in GCB subtype. And certainly high-risk patients, as we would have anticipated. So the study, which will recruit a total of 850 patients, is ongoing. It's a true multi-center approach of 39 countries, over 300 sites, including India and Poland. And I must just say that I do recommend participating in this study. We have contributed over 10 patients so far, and it seems to be one of the studies which may tip the balance. Now, what's truly hot in the first line are biospecific monoclonals, and let me just talk you through of what was an ASH. So it was EPCO plus R-CHOP, EPCO plus R-minute CHOP, and the other things with GLOFI. Now, the fixed duration EPCO plus R-CHOP induces high remission rates. And if you look at the phase 1 studies, including just over 40 patients, additional EPCO actually made a magnificent change in response rate. We observed over 91% of complete regressions and 100% of response of partial and 100% of overall response rate with 9% of partial responses. This looks like a breakthrough. And the progression-free survival in this run-up phase was pretty good, with 83% of patients being in a complete regression at 2 years. It was moderately well tolerated, but by moderately well tolerated, I want to say that biospecifics do increase the incidence of neutropenias, but this is something we hematologists can deal pretty nicely. Otherwise, nothing which would be of particular consideration or particular problem. Oh, perhaps I should mention that COVID is always a problem, regardless how far from China you are. And we tend to say that clinical studies are not for the idiots, and we tend not to suggest patients unvaccinated for COVID to participate. Now, the EPCO was not just investigated, the R-CHOP with EPCO was not just investigated by the company-sponsored studies. There were another approaches presented in abstract forms, and I show them just to demonstrate that the results were absolutely identical to what I have mentioned. Therefore, we have the already completed study on EPCO plus on R-CHOP plus minus EPCO, and this was again a truly multi-center approach. The study was the last patient was recruited not in May. That's the old slide. It was actually the last study was entered in 2023, and we are waiting for the readout. And it was a very simple approach, taking sorry, not, that's EPCO 1. And this was a very simple approach. Sorry, I mixed the slides, but anyway, this approach was R-CHOP plus minus EPCO. Now, the other presented study was in relapsing refractory setting, but this I may not want to say now at the moment. Sorry, I mixed the slides. Now, the other possibility was just to add EPCO to our polar RCHP. However, with this, I would like to make comments later when I will be talking about our polar RCHP plus minus GLOFI study. What I want to draw attention to is an approach for the elderly, where they just gave not R-CHOP but R-minute CHOP, and this was in patients who were incapable of getting the full dose of chemo. Elderly individuals, the median age of 81, range 74 to 80, and this is what I would like to draw your attention to. Again, we have 88% of progression-free survival at over a year, 92% of overall survival. Again, the response rates were absolutely excellent in this age group. So perhaps for the biospecifics, we don't need that much of chemotherapy. We also had a possibility to give EPCO in a monotherapy to the elderly patients. And in this study, it was a randomized approach, and on ASH, we just demonstrated the results of the so-called standard arm. So of a monotherapy arm, we did not reveal because there was not yet a pre-planned statistical analysis. So we didn't reveal the results of EPCO plus lenalidomide arm. So in a monotherapy, in the elderly patients, again, the median age of 81, with nearly 60% of patients with high-risk IPI, 3 to 5, we achieved in a pretty much comorbid group, we achieved an excellent response rate with 70% of CRs, overall responses of 80%. And mind you, these are 80-year-old ones and older patients. And this occurred that the age was not a risk factor, and that a high tumor burden was not a particular risk factor. Again, with a median progression-free survival, and this is an epcoritamab monotherapy of about 9 months. It was 8.1 months, and that's a monotherapy with epcoritamab for the elderly. So it looks like the biospecifics are effective in the elderly, although we would rather use it with a dash of chemotherapy. EPCO on its own was very well tolerated, and as you see, if you add chemotherapy, we do have neutropenias. In EPCO monotherapy, we observed just 30% of grade 2 and only 5% of grade 3 CTCA neutropenias. Sorry. Neutropenias we didn't observe at all. It was just a cytokine release syndrome. Sorry, you must forgive me, but 7 a.m. in the morning is hard, but I understand the time difference. Now, we mentioned about R-CHOP plus minus EPCO, then R-mini-CHOP plus minus EPCO, and then there is a global phase 3 study, which is taking polar R-CHP plus minus GLOFI. And again, it's a vast study all around the world. And we do participate in the study. The recruitment was already completed, at least for the countries like Poland. That's in the study designs. It's like this, that usually the outside of the US world recruits faster, but the study has to wait until the US recruits what they have to recruit. Now, my comment is that we used to have in Europe something like 30 years ago quite a good war film. It was One Bridge Too Far, and it was about the invasion in Netherlands once the coalition tried to reconquest what the Germans took in the World War II. And One Bridge Too Far was an excellent film, you know, with Redford being still young, but it as an operation, it was a disaster because the target was too ambitious. And it looks like, from my very limited experience, because we entered about 20 patients to this study, that the too much chemotherapy may not be what's really necessary. We had a lot of neutropenias and a lot of complication. However, what was demonstrated in the ASH meeting was a coalition study where we have polar R-CHP with GLOFI as well. And in this study, small study with 80 patients on board, 40 patients in this line, the GLOFI polar R-CHP seemed to be well tolerated. I'm saying seem to be well tolerated because they demonstrate here that the incidence of neutropenia were specifically grade 4 was greater in Glophy RCHP than Glophy polar RCHP, which would be not in line with our experience. But in both arms, they achieved 100% response rate, 98% of complete regressions. So we have to wait for the result of these studies. In the next couple of years, we will have R-CHOP plus minus EPCO and polar RCHP plus minus Glophy readouts. And I think that together with R-CHOP plus minus GOLCA, this might be the true step forwards. That's again to demonstrate you progression-free survival in this little 80-year study with 80 patients on board, and overall survival with a median observation time of about a year. And here I would like to stop the first line and go for the relapsing refractory setting. And what's in relapsing refractory setting? Well, the biospecifics, we had an upgrade of what was already mentioned in EPCO, Glophy, and Odro. So there was a freer update from EPCO NH1 study where epcoritamab was given as monotherapy in time-indefinite manner. And again, it was confirmed that there's a durable complete responses, but I want to warn you, all those magnificent curves are usually overall median of ongoing complete responses. These are the fake curves. They do not represent all patients. They represent only the patients who responded completely. Nevertheless, it's a relapsing refractory setting. At 36 months, we used to have a median progression-free survival for the complete responders. One comment about this study. Formally, you can give epcoritamab until unexpected toxicity or progression. Now, we had a lot of patients in this study, and we never had this EPCO carried on indefinitely. We had a bitter lessons once we lost patients due to infections, incomplete regressions at 36, 42 months. So we used to say that if you have a sustained complete regression, we took the patients off the study. And I present a comment if asked, what do I prefer, a time-limited Glophy and time-unlimited EPCO? For my patients, I said, well, I would rather have a time-unlimited EPCO, because in EPCO, it's me, the physician, who decide when to stop. It's the best for the patient if you're experienced. However, if you need stringent guidelines, or if the patient has a construction where they want to follow what's in the scriptures, Glophy might be better. Now, it was confirmed in a subgroup analysis of this study that the patients which had the CAR T cells, the previous CAR T cells, are doing fine. But I would say no wonder. No wonder, because they are saying the patients failing CAR T cells, which is rubbish. We didn't take CAR T cell failures. We took the patients who responded to CAR T cells and relapsed. Well, there were early relapses as well, but we didn't took a truly refractory patients. Therefore, if patients actually responded to one kind of immunotherapy, they should respond to the other as well. Therefore, for me, the subgroup of patients failing CAR T cells, in a way relapsing after CAR T cells, even early, is not the very high risk group, and therefore the results are very comparable with overall population. Now, there was an upgrade of fixed duration glofitamab monotherapy, and again, what they demonstrated was the excellent results of those patients in CR and not so excellent of those with partial regression or no regression. There was an upgrade after 24 months. The EPCO was the upgrade after 36 months. The responses are durable, if they are, and confirmed by ctDNA. But I wanted to draw attention to something else, namely to the immune recovery, which is very clear in terms of B-cell numbers after the cessation of the therapy. So if you have the end of therapy at 6 months, you are starting to see B lymphocytes at 12 months onwards, which could mean that this is the way to use in patient if the patients may have infections. There were some odronextamab results, but odronextamab is just approved in Europe, not in the States. Pretty much the same. There's not a large difference between any of these products. So how to improve the bispecific monoclonals? Well, a lot of ways to improve, but I just want to draw your attention to a star glow, which was not presented on ASH meeting. It was presented on the EHA, and that was one of those small studies, because if you have less than 250 patients, just 274 patients on board, it's a relatively small study, where it's 2-to-1 randomization, Genmab plus Glofi versus R-GemOx, and it elegantly demonstrated the subgroup analysis and so on, and it elegantly demonstrated the meaningful, significant overall survival difference. How many studies on less than 300 patients we have which demonstrate overall survival difference with such a short follow-up? Therefore, it again demonstrates you that a dash of chemo, because R-GemOx or GemOx is a dash of chemo, plus biospecifics might be beneficial. That's why I'm so enthusiastic about our mini-CHOP results, which may occur in the elderly to be as good as R-CHOP results in the youngsters, certainly if given with EPCO. So there was the response rate, overall response rate of nearly 70%, including nearly 60% of CRs, is a good result in relapsing refractory setting. It's true regardless the subgroup analysis, and the safety profile summary did not reveal anything we can't deal in a Glofi GemOx arm. And certainly we had some cytokine release syndrome, but we all manage. It's all manageable. It's nothing like in the CAR T cells. We have never lost a patient to cytokine release syndrome in any other biospecific studies, and we gave her and we dosed more than 300 patients with biospecifics. However, COVID, as usual, is a problem, and there are more COVID-related deaths if you are talking about the biospecifics. Now, there were lots of papers demonstrating that the R-GemOx with Glofi in a STARGLOW study is sustained, cost-efficient, because they've done all this pharmacoeconomic analysis, saying that this GemOx plus Glofi is really feasible from economical point of view. Another poster on economic analysis, just to show you that it seems to be the cost-efficient way of therapy. Now, how to improve EPCO? We had this fixed duration EPCO plus lenalidomide, and again, the results were reasonable at 12 months, with 87 or 78% of patients still responding. There's a phase 3 randomized study with EPCO plus lenalidomide compared with R-GEMOX. This is an ongoing protocol, and well, I mean, it's a protocol which is facing problems in recruitment because we all know that an arm with APCO will be better. Another study with Gloffy, showing you how we dose the Gloffy, and this is the patient. These are the patients after failing at least one prior line of therapy. And again, excellent response rates, manageable toxicity. There's a plethora of those studies. I want to draw attention to few things, like polatuzumab, which is a targeted chemotherapy, is anti-CD79B. And it occurs that anti-CD79B antigen as such is in fact acting and upregulating CD20 expression. These are lab data, but it looks like that a combination regimen where polatuzumab is given with biospecifics may be effective. And indeed, there were studies investigating this regimen in relapse refractory diffuse large B-cell. We can't say whether these response rates will be significantly better to monotherapy, but this is how they tried. Pretty well tolerated regimen. And the same thing were, well, that's Gloffy plus obinutuzumab. Sorry, I put all those slides, but there were too many. Now, there was a couple of studies, and I took one at the end to show you that that there are approaches where the CAR T cells are followed by biospecific consolidation, but this is something which might be the future. Looking at my watch, I more or less have this half an hour, but I would rather have more discussion than preaching. So to summarize what was on ASH, we are living in interesting times where we have more and more interesting alternatives, and we can really, we are really witnessing the fact that R-CHOP will no longer be the true standard of care, that we will be able to do something more for our patients in first line. In a relapsing refractory setting, the modern immunotherapy will change the perspective. Now, perhaps the last comment is, what about the small particles, and what about all those molecular targeted agents in diffuse large B-cell? I didn't mention them at all because I think that we're not prepared to them. And certainly there were approaches something like 10 years ago when we randomized patients between R-CHOP plus minus ibrutinib, which was a bitter lesson because it occurred that the protocol, the combination worked well in the youngsters, but not so well in the elderly. And there was a bitter lesson because it occurred that it was absolutely perfect in one molecular subtypes of ABC, but not doing a difference to the others. So in the youngsters, which could tolerate the therapy well, additional ibrutinib did not change the dose intensity of R-CHOP. So in the youngsters, there is the progression-free survival was 10% better, just because it was active in MCD subtype of APCs lymphomas. For the elderly, on the contrary, additional ibrutinib decreased the dose intensity of R-CHOP, and therefore we had a failure. And the big, for me, the conclusion is that the small particles may be used, but we have to learn what are the true large B-cell lymphoma subtypes, and we have to transfer this knowledge to the labs so that the diagnostics is better on the everyday level. So far, we can't do it. Therefore, without the possibility to identify a particular molecular subtype, the molecular target agents are not yet on the run in large B-cell lymphomas. However, they may come, and some very preliminary studies show that this will be the interesting alternative. Nevertheless, that's all I have for today in a preaching part, and I will be very happy to take the questions.
Thank you, Professor Juzak, for that wonderful lecture. As always worth to listen to you. Fantastic, sir. And just to keep the ball rolling from my side, one question I have. In case of those patients who are transplant ineligible, we usually prefer salvage therapy relapse refractory setting with RGMOX. Is it time to come that we should go for bispecific antibody with only APCOR unlimited therapy, monotherapy?
Well, we are talking about, I'm not quite convinced what you can use in India, and will you have to follow all which is approved or not. Now, if I had the elderly patients nowadays, I would do everything possible to give them a dash of chemo plus biospecific. And by a dash of chemo, I would certainly start with our mini-CHOP, which we are actually trying to start in Hovan, a randomized study where there will be an R-mini-CHOP versus R-mini-CHOP with EPCO. And we had a kind of discussion because, you know, Hovan is a Dutch study group, and they are slow in preparing the studies. The study design was great 1.5 years ago, but it's still not ongoing. So I thought that it might be better just to have a larger group on mini-CHOP with epcoritamab, just to demonstrate that this is sufficient. Because as we will have the readout out of the R-CHOP plus Minos EPCO study, it will be approved, and then I thought that we could use it. However, eventually they decided to carry on with the original protocol. So this will give us the eventual answer. But out of the data we have so far, a dash of chemo plus biospecific, or if you like it, lenalidomide plus biospecific. But I just want to draw a conclusion that both a dash of chemo and lenalidomide, they both cause neutropenia. So we're not gaining a lot. So it's presumably up to you what you use.
Thank you, sir. Dr. Lalit Kumar, sir. You're muted, sir. Please unmute yourself.
Thank you, Prof. For the great talk.
Sir, if you can close one of your video, because you opened up from 3 different devices.
No, I think
There's an echo because of that.
oh, okay.
Hi, sir.
I just come to you.
Okay, so I think maybe I'll just try to sort it out meanwhile.
Or you can type it in the chat box, sir.
Just wanted to say that it's a great talk, and wanted to know, is there any place for rituximab-based therapy in the relapsed refractory lymphoma?
If I got the question, you asked about rituximab-based therapy in large B-cell lymphomas.
Yes.
It just reminds me the very old study Roche did. They used over 800 patients to document that obituzumab with CHOP was not better than rituximab with CHOP? Well, obinutuzumab is clearly a better monoclonal antibody, and we all agree to it. But CHOP is a very strong chemotherapy. Therefore, we need some monoclonal antibodies, but possibly if it's just if the antibody is just better and not super better as biospecifics, it's not enough if you have the immunity checked by CHOP chemo. So I think that R-CHOP is still a very good standard of care used for comparisons. I think we will change it eventually, but if you look at the GOLCA study, in GOLCA, which the study was planned after we already had the polar RCHP results, and we still electively thought that R-CHOP in a comparator arm is better, and combining GOLCA with R-CHOP is better than combining GOLCA with polar RCHP. So I'm not answering your questions directly because it's not just rituximab I'm referring to, but I think that R-CHOP was the standard of care and was undisputable standard of care, and we need much more heavy shelling to forget about it. So yes, in a way, I still think that rituximab-based therapies will be for some time very useful.
The second question was whether after the initial response in relapsed refractory lymphoma, should be is any place for transplant if they achieve CR with the bispecific like EPCOR? Or
Thank you very much for this question, because in the old days we used autologous transplants in all high-risk cases, not because we had randomized studies, but because the fate of those patients once they relapsed was so bad that we thought that we may make the overall survival better by early intensification. Now, I think it's completely not to be recommended in 2024 for two reasons. We want the patients to be treated as efficiently as possible in the first line, but as efficiently as possible would in 2024 mean either in clinical studies or with polar RCHP. And those in a true PET confirmed CR, I would just leave on their own. However, I would monitor them closely to get them to the CAR T cells in the first relapse. So my answer is, if you have the access to CAR T cells in the first relapse, I would not transplant any patients, the patients anymore as a consolidation of the first line.
and also we'd like to make comments about the radiation in patients who have got some partial response or localized residual tumor left after the EPCOR therapy.
So residual disease after epcoritamab. Okay, is there any role of localized radiotherapy?
Okay. EPCOR, we want to give radiotherapy for the local disease which is not responsive and is PET active. We have problems with PET assessment after epcoritamab therapy. We have problems because we have a relatively good experience in PET in early response assessment during chemo, but even though we know that we will have false negative results. Now, if we have an early response in EPCO-treated patients, after chemo in early response, we might have the risk of false negative results. After EPCO, we might have the false positive results. Now, we don't know the exact time which will give us the true answers, because in chemo or in chemoimmunotherapy, we tend to say that the PET scan done 6 weeks after the last dose is the true PET. Now, after EPCO, we don't know it. So why I started through this, because EPCO is indefinite therapy. So my way of looking at it, if I see the patient who is responding to epcoritamab and is tolerating it, and in PET analysis is still positive, I would think, okay, it might be the false positive. I will not know whether that's a false positive or not until I stop the therapy. But why should I stop the therapy, as this is a time indefinite therapy, usually well tolerated? So my way of life with those patients is I tend to keep on EPCO without radiotherapy and observe them, and maybe do another PET scan in 3 months and see how they are doing. Now, if you ask the question, do we change the therapy or do we do anything else if we see a patient with an immense tumor burden, like bulging tumor, which maybe there was a tumor reduction from 10 centimeters to 7 centimeters, still PET active, and whether we use radiotherapy there. Again, as in Poland, giving radiotherapy would possibly mean the necessity of stopping EPCO, and as lenalidomide is now, fortunately, such a cheap drug, so that even if the system doesn't allow it, patient can afford it out of its own pocket. The first thing I would add lenalidomide to EPCO, as this increases efficacy. And it's not that I'm saying that radiotherapy is wrong. No, I have no experience in radiotherapy and EPCO together. And, patients are getting more and more, how shall I put it? We are taking the bad things from the States as well. And simply the patients tend to sue us. So no, I would not have the strength to stop epcoritamab in patients with a partial response. If it's a progressive disease, that's clear, but it's a partial response, I will not find enough courage to stop epcoritamab and give alternative therapy. I know that the prognosis is poor, but I don't know what the patient's family will do.
Thank you so much. Thank you, sir.
Thank you so much, sir. That was a fantastic, overview of APCOR and, whether to give RT or not. That was great. Brilliant, sir. Dr. Anup Tosniwal, your question.
But
Hi, sir. I'm Dr.
Just one last comment. I really, because if you have a demanding patient, which may ask lawyers if something goes wrong, or if you are not experienced, I would go for Glofi. Glofi is so easy. You have time-limited therapy. You don't have to worry about. You give everything according to scriptures, and that's it. If you have your favorite patient, if you're experienced, I would go for EPCO, because it's on you when to stop it, how to change it, how to modify it.
Great. Thank you, sir. Dr. Anup Tosniwal, your question.
Hello, sir.
Yeah.
Hi. Yes, sir. I just wanted to know if there is a concurrent CNS lymphoma. Where does polatuzumab stand upfront? Like Pola RCHP alternating with methotrexate-based regimen. How do you go about where there is concurrent CNS lymphoma associated?
Thank you for this question, because, you know, we had a lot of discussion what to do with the central nervous system lymphoma, and or with the risk of the central nervous system lymphoma, and whether we should or should not give all those methotrexate stuff and so on and so on. We have the risk factors, and I can just tell you what I do. In the first cycle, if we have just the high risk and not the proof, because if the patient has a central nervous system lymphoma, it's the other story, we treat them differently. But if we just have a high risk of the patient, I give them the first cycle without any additional things. Just because I think that if you're doing the LP to get the cerebral spinal fluid to examine it, just if you have the high lymphoma burden, it's a very hypothetical, but a possibility that you will introduce the disease into the central nervous system by LP. More to it, you don't know how the patients react to the first cycle. It's usually the worst cycle to give in terms of metabolic consequences. So the first cycle I give as it is. But in the second cycle, if you have the high risk, I always do the LP with a very meticulous flow cytometry analysis. And I just divide the patients to those who are clear and those who are not clear. And those who are clear, I do nothing at all. Maybe at the end of therapy, I take the patients, take the families and say, okay, you know, you had a high risk disease. You are in complete regression. We may go one step further, although we are not certain whether this is necessary or not. And we may give you this methotrexate as the 7th, the 8th cycle. I do not give it during the therapy, as I don't want to jeopardize the dose efficacy of whichever the schedule I use. I'm not convinced enough to recommend it in those patients. But as I mentioned, patients' families has lawyers. So well, if we don't know, we discuss it with them. Now, out of my experience, less than 20% of patients decide for additional methotrexate. Now, the most interesting part are those patients who have lymphoma cells in CNS analysis. And in those patients with the cells in cerebral spinal fluid with confirmed lymphoma, I have trust in my flow cytometry lab. And if the lymphoma is confirmed, we do whatever is more suitable. If we have a minor disease at the outside central nervous system, we sometimes change completely to the schedules for central nervous system. However, if we have a high tumor burden outside central nervous system, these are those patients where we tend to give normal chemo with high dose methotrexate, which has the risk of dose intensity. But if we have a confirmed disease in the central nervous system, we treat it as a central nervous system lymphoma. Certainly the prognosis is not magnificent.
Any other question?
Answer, but I need to ask one more thing. If there is involvement in the CNS, like CSF involvement versus parenchymal involvement, the treatment strategy will change. Plus, where there is a systemic disease also, there's a concurrent CNS involvement, two scenarios, systemic disease plus CSF involvement, systemic disease with parenchymal involvement. The both strategies will change. And where we give a do we use polatuzumab plus RCHP as a chemo background? Alternating with matrix or alternating with MTR or alternating with only high dose methotrexate, and do you consolidate them with upfront autologous stem cell?
Again, a very good question. I mentioned that if you have a proven central nervous system disease, either in the imaging studies or in cerebral spinal fluid, we have to address it. And if you have the abundance of disease outside central nervous system, I add methotrexate. And yes, I do consider stem cell transplant and consolidation. I mentioned that we don't do stem cell transplants. Absolutely, you're right. In this group, we do it. But we address it as a central nervous system disease. And for me, the proof of the central nervous system disease is either radiological or in flow cytometry, which I perform after during the second cycle. If the result is positive, it's documented in the patient's history, and we regard this patient as a very high risk. We treat him differently. So once again, I will not be able to give you the guidelines that in all the patients you have to do the same. If you have just some involvement outside central nervous system and the central nervous system disease, we have the protocols specifically dedicated for central nervous system, and they also include the transplant at the end. If you have an abundance of systemic disease and just a scanty involvement of the central nervous system, I tend to give them the methotrexate. However, methotrexate with the normal chemo. However, we usually somehow we're looking at how the patient is reacting. There's no a standard. So if we have at some point a PET CR, then perhaps we would not even go for the end of the 6 cycles, and because with the methotrexate we will have problems in mobilizing the stem cells. So perhaps we would give this cytarabine to mobilize the stem cells as cycle 4 or cycle 3. It's all individual based. I don't have the good recipe for everyone. We don't have the statistics, and these are very difficult patients. We treat them individually.
Thank you, sir. One more question. Is there a role of venetoclax in relapse refractory large B-cell lymphoma? Like we use in Ritter's transformation, like we use CHOP plus venetoclax in Ritter's. So is the role of venetoclax plus chemo backbone in relapse refractory large B-cell?
Again, a very good question. Now, if you're asking, may it help? I would say absolutely it may. If you ask me, will I give it? Well, outside clinical studies, possibly not. Because it's interesting action. However, we don't have any proof. I want here to give you the preliminary results on one of the studies where we could enter, in fact, most of the B-cell lymphomas to sonrotoclax study. It's another BCL2 inhibitor, but I'm not saying this because I'm convinced that sonrotoclax is better than venetoclax. I'm just saying that there's a study with a BCL2 inhibitor. And we did observe responses across the diagnosis. However, the best responses we observed were in mantle cell lymphoma. And we also had a poster on ASH on the patients on the CLL patients who failed pirtobrutinib. And in those patients which were previous failures of the first and second generation of BTK inhibitors, and they used to have venetoclax as well, some of them. However, of the patients who failed, the median progression time on pirtobrutinib was about 8 months. Now, out of these 120 patients, we analyzed them afterwards, and it occurred that in 80 out of these 120 patients, we gave venetoclax. And it occurred that venetoclax given after pirtobrutinib, so after the third generation BTK inhibitor, had in fact a magnificent progression-free survival. The median progression-free survival on venetoclax in this setting was 18 months, as opposed to 8 months on pirtobrutinib. So this is just to tell you that, yes, the BCL2 inhibitors are very important and may change our perspective here, but we do not have any formal clinical studies to confirm it. So if you're talking about a heroic medicine, yes, you may give it, but in Poland, I will not dare to do so unless it's in a clinical study.
Thank you, sir. If I ask my last question,
Please go.
I'm curious about this. I don't know if it is right or wrong. All these large B-cell lymphoma are CD19 positive. So why there are no studies of inotuzumab, the CD19 ADC? Because many times when we have a relapse setting, we have the CD20 down regulation. CD20 is many times negative, and if we have CD20 many times negative because of down regulation, so can we not substitute with CD19 ADCs? Like, why are there no studies with CD19 ADCs? Like we have in ALL, lymphoblastic leukemia.
Well, the question is, what do your CAR T cell doctors tell you? Because in Poland, they have they very much dislike any anti-CD19 approaches before CAR T cells. So if the patient is a likely CAR T cell candidate, and if it will be feasible to give them CAR T cell, perhaps the CAR T cell would be the first anti-CD19 therapy I would try. Otherwise, we developed this naked anti-CD19 monoclonal tafasitamab. And I certainly do not recommend tafasitamab in young, relapsing, refractory, aggressive patients. But if you have the elderly, tafasitamab plus lenalidomide is doing the job pretty nicely. Now, if you're talking about anti-CD19 targeted chemotherapy, like Lonca, it's quite a good idea, but it will not cure the patient. The tafasitamab will not cure the patients. It's one of the palliative approaches we may consider. If you're asking whether tafasitamab may replace anti-CD20 therapy in the upfront setting, we do not have the proof that it may do so. And again, I'm not convinced that giving tafasitamab or other anti-CD19 therapies will make CAR T cells impossible. But perhaps they can make that inferior. So if you have the access to the CAR T cells, your way of treatments might be different to the moment that you do not have the access to the CAR T cells.
Thank you, sir. Thanks a lot for answering all my questions. Thank you.
Thank you. So we have some questions from the audience. I will just start from the Dr. Gopinathan. 66, he has got a 66 years old male with no comorbidities. His performance status is 2, late relapse, DLBCL after 8 years. And the site of involvement now is paravertebral region plus leptomeningeal region. So what would be the ideal approach in this treatment in 2025? 66 years, male, no comorbidities, performance status 2, late relapse DLBCL after 8 years initial therapy.
I would just ask the audience, do you believe in late relapses of aggressive lymphomas? Because I'm never certain whether in such a patient we have the late relapse or we have the patient with some kind of predisposition for lymphomas, and that's a second time he got the diffuse large B-cell lymphoma, but not as a relapse, but because of a totally independent thing. 8 years, it's a long time. So whatever is the answer, possibly we should treat this patient as the first line diffuse large B-cell lymphoma. However, in this patient, we can't use anthracyclines. So if you ask me what or how shall I treat him, as for the European standards, he would not be eligible for the CAR T-cell therapy because it will be the late relapse. So we would possibly need to give him some kind of chemo. And for the chemo in a relapse refractory setting, I think that after the StarGlow, a biospecific with a dash of chemo seems to be magnificent. So I would, if the money is not a problem, I would give him Glofi with Gemox. And if this is not effective, CAR T-cell in the third relapse for him, in the third relapse or the second relapse of the second time the lymphoma occurred there.
And this patient has got paravertebral involvement as well as leptomeningeal involvement now.
What involvement?
Paravertebral involvement as well as leptomeningeal involvement.
Did I get well that he has a meningeal involvement? So the
yes,
central...
leptomeninges are involved.
Oh, come on. So then we just treat him as for the central nervous system lymphoma with a protocol dedicated towards that. We can't have any other possibilities.
Exactly.
And the diagnosis is not that good.
Perfect, sir. Another question from Dr. Leong. Will there ever be maintenance therapy for DLBCL? As it seems that you are giving epcoritamab for lifelong and long-term till the disease progression. Is this somewhat like a form of maintenance therapy in lymphoma?
I want to say that epcoritamab should not be given lifelong. Or in a way, if someone is Medicare and wants to give epcoritamab endlessly, he will give it till the end of the life of the patient because he will lose the patient on infection or something else. So epcoritamab allows you to be used as long as it is necessary, which doesn't mean lifelong. So otherwise, answering your question, epcoritamab is just another time-limited therapy. However, it is the doctor who gives the limit, who defines the limit.
Thank you, sir. Another question from Dr. Leong. Can we repeat using rituximab in salvage chemotherapy for DLBCL despite the biopsy showing CD20 negative?
If you have something which is clearly CD20 negative, now using any anti-CD20 monoclonal is not justified. However, I want to give you one perhaps exception. Then it occurred that you can use brentuximab vedotin in CD30 negative lymphomas. And we really had the data, randomized data, demonstrating that it was effective. Now, we tried to find out how possible. And it occurred that if you have a targeted chemotherapy, even a very low expression of the antigen might be enough. But this is perhaps true for the targeted chemotherapy. This is definitely not true for a normal naked monoclonal antibody. And it's possibly not true. We have no data on this for the biospecifics. So if someone is CD20 negative, I would use tafasitamab if I need a chemotherapy combination. And I would just use tafasitamab if it's anti-CD19 positive. And certainly I would use tafasitamab as rituximab, just with whatever the chemo you like. And in case of doubts, I will try to go with the CAR T cells as fast as possible in this patient.
Thank you, sir. Another question from Dr. Leong. For golkedamide in relapsed refractory DLBCL, is there a concern about thrombosis? And is prophylactic anticoagulation recommended when the patient is on golidamide?
Patient specific, but we give antithrombotic prophylaxis to 90% of our patients while on therapy. Then, if the disease is gone, it depends on how large the residual mass is. In patients with large residual masses, sometimes we tend to go for the long-time prophylaxis.
Thank you, sir. Another question from Dr. Krishna Ratnam Kannan. In case of relapsed patients who respond to salvage chemo, what would be your preference now in 2025? Whether CAR-T or autologous stem cell transplant?
Neither. Sorry, CAR-T cell. Yeah, CAR-T, absolutely. Well, I do not think that a salvage is any longer a salvage, because what we want in a relapsing refractory setting, if we go for the modern immunotherapy, we want some tumor burden reduction and not necessarily a salvage chemotherapy. Just, there might be funny to mention, but our patients may live long on one condition, that we don't kill them with our intensive therapies before. So the role of intensive chemotherapy is decreasing and should be used after the intelligent approaches failed, and then possibly will have no effect anyway.
Thank you, sir. Another question from Dr. Leong. I think it's a repeat question. Oh, yes. In case of DLBCL, stage 4, with CNS involvement, you said we can give R-CHOP plus high-dose methotrexate in the same cycle. So on which day should we use this high-dose methotrexate? Whether to give on day 3, day 8, day 10, on which day of R-CHOP?
If it's a central nervous system involvement, which is a confirmed involvement, again, I go back to what we do. If we have just some peripheral disease, not bulging, we go for the central nervous system dedicated therapies, which are completely different. And if there's just a dash of this, it doesn't really matter when you give methotrexate. It has to be given as a 1 dose per cycle. It all depends on what your local preferences are and what your local policy is, because if you give methotrexate, then you have to give this tetrafoliate, and you have to monitor for the methotrexate level. So it keeps you keeping the patient in hospital for at least a couple of days after methotrexate dose. Now, then, if you have the cytopenias after methotrexate on their own usually happen 7 to 10 days later. Cytopenias after CHOP may happen earlier. So if you have the patient after tetrahydrofoliate in an agranulocytosis, in a grade 4 neutropenia, and possibly facing the severe mucositis or a possibility of mucositis, grade 4 neutropenia plus any degree of mucositis means a problem. So you possibly need to keep this patient as an inpatient. So it all depends on the local preferences. If the patient is fit, I would rather give it as close to day 1 as possible, just to shorten the hospital stay. But if the patient is not fit, presumably I will go CHOP first and then postpone the dose of methotrexate, but this will mean that the patient will be inpatient for a long time.
Thank you, sir.
But nevertheless, we never give 2 cycles of chemo during one hospital stay. So if the patient needs to stay for 3 weeks, I still kick him out of the hospital for at least 2 or 3 days, just to let him breathe.
Thank you, sir. Another question from Dr. Anup Tosniwal. In countries like us where we do not have access to glofitamab or apcotamab very easily available, these two agents are not that available in our country. Can we go for simple POLA-BR or POLA-ICE followed by autologous stem cell transplant? Is this two regimen too toxic to go for a stem cell transplant? POLA-BR or POLA-ICE, then stem cell transplant, autologous?
Both are fine. However, what is the availability of the CAR T cell in India? Because this is a key question, because this is a game changer. If we used to, because I remember that in Poland we have two eras. The era of the right-wing government, which tends to tell the people that they are helping them, but in fact they didn't reimburse any drugs. And when the government changed, within 12 months, it occurred that there was a revolution. We now have all the drugs reimbursed. So a year and a half ago, I was able to treat 30% of my patients according to the Western standards. Then we kicked the right-wing extremists out, and now I may be able to treat 80% of the patients according to the Western standards. So the perspective is important. And if the CAR T, we had the protocols where the CAR T cells were not available. They were officially available, but they were very limited. And if this is the situation in India at the moment, so this will resemble what the situation we were in just a year ago, there we had two solutions for this miserable situation. The first solution was we developed networks of clinical study centers, and we tried to have as many clinical studies opened as possible. And the second solution was to treat the patient with whatever we had. And in the era where we have a targeted chemo, but we do not have the access to any modern drugs, the polatuzumab in a second line had a good literature. There were gave you the progression-free survival and overall survival benefit. But there's always a question whether you may use it with bendamustine before the transplant. So my way of treating those patients in that era was indeed the way your colleague indicated. I used polatuzumab with something else. I gave it with ice if the patient was in a good condition. We tried to make those patients, at that time, and again, it was local possibility. Drugs were limited, by PET scans were not limited. So we gave them the first cycle and we checked the response after the first cycle so that we tried to mobilize the stem cells during the second cycle. It was always like this, that we did the PET scan and we started the second cycle and we didn't yet have the PET scan report once the second cycle was started. So we tried to arrange it in a way that it could be the mobilizing cycle in terms of days of the week and things like that. So we had to play around with all that. So yes, polatuzumab was available, and so we used it. For the elderly bendamustine rituximab with polatuzumab, why not?
Exactly. Thank you, sir. And one more question he has. If the patient undergoes CAR T cell therapy, is it necessary to consolidate afterwards with autologous stem cell transplant?
Sorry, I didn't get it. Autologous transplant after the CAR T?
Yeah, after the CAR T.
No. Please no. Please no. I just want to remind you that if you look well enough, we may see the CAR T cells. We may find the CAR T cells 18 months or perhaps even 24 months after the CAR T cell therapy. So the last thing you would like is you would like to give those patients therapy, which would get rid of those remaining CAR T cells, which could still be active. So I would be quite in favor of giving something after the CAR T cell if you think that the patient is of high risk or whatever. If you want to play the role of Mr. God, you may give them lenalidomide. Why not? I'm not saying that biospecifics, but I would be the last one to give chemotherapy to the patient on active immunotherapy because we don't know how long the CAR T cells work. It may be that they are still effective 6 months and 12 months afterwards.
Exactly.
So
Thank
not
you, sir.
consolidate those patients with high dose.
Great. Thanks a lot, sir. So I have finished all the questions from the chat box. Any discussions over here? Want to ask any other question? Well, I think there are no more raising signs. So again, I may say, fantastic teacher you are. You have solved all our doubts today. What a wonderful discussion we had today. Brilliant discussion, brilliant lecture by you. And I think hats off to you for a wonderful lecture, wonderful discussion, and what a knowledge you have in this field, sir. Thank you so much for having you over here as our guest speaker for the day. And I really thank you to join here today, sir. Very early morning for you. Thanks a lot, sir. And I also thank.
Thank you for organizing this marvelous meeting. I may just tell you that I look outside and it's snowing. We have 20 centimeters of snow last night.
And that too very early morning.
7 a.m., yes.
Thank you so much, sir. Thank you once again. And I thank all our discussants as well as all our audience to participate in this webinar. A very special thanks to Dr. Jurczak for joining us today with a snowing morning, early morning. Hats off to you, sir. Thank you so much. Goodbye for now and meet you next week with another beautiful webinars. Thank you. Bye-bye.
Thank you.
Thank you. Thank you, sir. Thank you. Bye.